fixed learning module is a permanent display of teaching and learning material which students go through at their own convenience. In the respiratory module, we have two fixed learning modules, one on pleural diseases and the other one on the investigation of lung diseases. This video is to supplement the fixed learning module on investigation of lung diseases. The objective of this fixed learning module is to look at the value of the examination of the sputum, lung function testing, bronchoscopy, chest radiograph, and some other special investigations. First, let's take a look at the examination of the sputum. Macroscopical appearance is useful. We subject the sputum to other microbiological examinations like gram stain, acid-fast stain, culture, and antibiotic sensitivity testing. When malignancy is suspected, sputum cytology is invaluable. When you collect the sputum, particularly for acid-fast stains, we ask the patient to cough as the first thing early in the morning before rinsing the mouth. We take 3 such samples and send them for the examination. Sometimes macroscopical appearance gives a clue to the diagnosis, like in the mucoid sputum, in chronic bronchitis and asthma, frothy sputum, classically pink frothy sputum in pulmonary edema, purulent sputum, bronchiectasis, lung abscess, and also in the resolving phase of pneumonia. Blood-stained sputum is alarming, seen in early stages of pneumonia, bronchial malignancy, tuberculosis, bronchiectasis, and in pulmonary infarction. Let's take a look at some of the microbiological investigations now. Sputum smears are examined after staining with gram stain. This might give a clue as to what the causative organism is. Culture will help you to isolate the growth and to test for antibiotic sensitivity. If the growth is a mixed growth, it's difficult to interpret. Streptococci are gram-positive organisms in chains. Staphylococci, gram-positive cocci in clusters. Klebsiella is a gram-negative organism, which is a cause of upper lobe pneumonia. And here you can see the pneumococci, gram-positive cocci in pairs. When you suspect tuberculosis, one does an acid-fast stain. Acid and alcohol-fast bacilli are not all that easy to detect. The culture on LG medium takes a long time. There are several basic lung function tests. Peak expiratory flow rate, or the PFR, is a very useful bedside test, but spirometry, the lung volumes and diffusion capacity are not commonly done. Let's see whether you can label this diagram. I'm sure most of you are familiar with this. The subject is breathing normally, the tidal breaths, and has been asked to take a deep breath and then breathe out fully. Now here's time for you to stop the tape, hit the pause button, and try and answer, try and label what 1 to 6 are. These are lung volumes and the capacities. When the music comes up, you can pause the tape. When you are ready, let's look at the answers. Number 1 is a tidal volume. Patient is breathing normally. And he has been asked to take a deep breath in and breathe out. That is a vital capacity. What remains in the lung after the vital capacity breath, that is number 3, is the residual volume. Number 4 is a functional residual capacity. That is what remains in the lung after a tidal expiration. Number 5 is inspiratory residual volume. And the number 6 is expiratory residual volume. There will be several exercises like this. We would like you to stop, pause the tape, and do the exercise before you proceed. There are several useful features of the peak flow rate. It supports the diagnosis of obstructive airway disease. The diagnosis depends mainly on the history and the clinical examination. It's useful to assess the severity of the obstructive airway disease and to assess the response to treatment. It's also useful to diagnose occupational asthma when you show that there's a drop in the peak flow rate with related to work. This is the peak flow meter. The subject is asked to take a deep breath in and breathe out as fast and as full as possible. In this case, the peak flow rate is about 500 liters per minute. It's about 480. Peak flow rate changes with the age and the height. This is a spirometer which is used to measure the vital capacity and the FEV1. This is the tracing we have obtained from this vital graph or the spirometer. Here, the vital capacity, the maximum volume of air blown out is 2.7 liters. FEV1 is defined as the amount of air that has been expired during the first second. In this case, it is 2.5 liters. This equation is useful. So FEV1 ratio is FEV1 divided by the forced vital capacity multiplied by 100. With the value we obtain for FEV1, we can categorize lung diseases between obstructive and restrictive. In obstructive, FEV1 is low, FVC is normal, but the FEV1 ratio is less than 70%. In restrictive, both FEV1 and FVC are low, but the ratio remains over 70%. Now here's a series of exercises for you. We would like you to calculate the FEV1, FVC, and the ratio, and then interpret whether it is normal or abnormal. When the music comes up, you can pause the tape and then do the exercise yourself. In this case, FEV1 is 3.1, forced vital capacity is 3.8, the ratio is 82%, and this is a normal spirometry chart. Exercise 3. FEV1 is 0.5 liters, FVC is 2.2 liters, FeV1 over FeV3 ratio is 23%. And this is an example of obstructive airway disease. Exercise 4. FeV1 is 1.8 liters, FeC 2 liters. FeV1 ratio is 90%. Here both FeV1 and FeC are low, but the ratio remains over 70%, and this is a case of restrictive airway disease. Let's take a look at the carbon monoxide diffusion capacity. This determines whether the alveolar capillary membrane is intact or not. In cases where the alveolar membrane is damaged, carbon monoxide diffusion capacity, which is a measure of the permeability, is affected. So let's take a look at these conditions and see whether carbon monoxide diffusion capacity is reduced or not. Asthma is a condition where there's a problem with the airways, therefore carbon monoxide diffusion capacity is normal, and so is the permeability of the alveolar capillary membrane. In emphysema, alveolar capillary membrane is damaged, and therefore carbon monoxide diffusion capacity is low, so is in lung fibrosis. Ankylosing spondylitis is a restrictive airway disease due to a problem of the rib cage. There's nothing wrong with the alveolar capillary membrane, and hence carbon monoxide diffusion capacity is normal. In polycythemia, because of the increased hemoglobin concentration in the blood, carbon monoxide is taken up more rapidly and more readily, and therefore carbon monoxide diffusion capacity is in fact increased. When there's bleeding into the lung also, because of the blood inside the lung, alveoli, it takes up the carbon monoxide, and is another cause of increased carbon monoxide diffusion capacity. Exercise 6. In these four conditions, you can work out whether vital capacity, total lung capacity, FeV1 ratio, and carbon monoxide diffusion capacity normal or abnormal. In case of asthma, vital capacity is normal or low, total lung capacity is high because of the air trapping, and the FeV1 ratio is low, and the carbon monoxide diffusion capacity is normal. Emphysema is another cause of obstructive airway disease where there is damage to the alveolar capillary membrane. Vital capacity may be normal or low. Because of the air trapping, their lungs are expanded and total lung capacity is high. And the ratio, FeV1 ratio is low, carbon monoxide diffusion capacity is also reduced. In lung fibrosis, there is a shrinking of the lung. Vital capacity is hence low, total lung capacity is also low. The ratio could be normal, carbon monoxide diffusion capacity is reduced. This is a case of restrictive airway disease with alveolar capillary membrane damage. In ankylosing spondylitis, another cause of restrictive airway disease, vital capacity is low, reduced, total lung capacity also reduced, FeV1 VC ratio is more than normal, that's more than 70%, it's normal, carbon monoxide diffusion capacity is also normal. This is in contrast to lung fibrosis. This is a flow volume law. This is the residual volume. Patient breathes in, this is the inspiratory limb, then breathes out fully, as fast and as full as possible. This is the expiratory limb back to the residual volume. Residual volume, inspiration to the total lung capacity, breathes out back to the residual volume. This is a case of normal flow volume loop. Number 2 is a case of asthma, where you can see the expiratory limb is markedly reduced and there's a concave appearance to that. Number 3 is an example of extrathoracic airway narrowing, where inspiration is more affected than the expiration. Radiology, one of the most useful forms of investigations in lung disease. Before we proceed, let's work out the exercise 7. I have labeled this diagram. This is a cartoon of the PA view of a chest radiograph. Let's see whether you can label this A to G. When you are ready, pause the tape, do the exercise, and then get back to the tape to look at the answers. A is trachea, B is aortic knuckle, C, left main bronchus. D, you could see the left pulmonary artery arching over the left main bronchus. E is a left hemidiaphragm, and you can see the gastric air bubble F below the left hemidiaphragm. G, right dome of the diaphragm. Right pulmonary artery H. Right main bronchus I, and the azygous vein J. Exercise 8 is a lateral view of the chest radiograph. A is the aorta, B, pulmonary conus, C, right ventricle, D, inferior vena cava, left ventricle E, left atrium the F, and trachea G. Let's take a look at some of the chest x-rays. This patient came with hemoptysis, has a cavity in the left apex and a ball inside that cavity. This is a case of pulmonary aspergilloma. This patient with chronic cough and purulent sputum had multiple cystic lesions in both lung bases. Cystic bronchiectasis. Can you see the horizontal fluid level in the left hemithorax? This shows that there's air and fluid. This is hydropneumothorax. This is different to a pleural effusion. This patient presented with acute severe shortness of breath. A snowstorm pattern or a bat-wing appearance was seen in the lung fields. Cardiothoracic ratio was more than 50%, showing that there is cardiomegaly. This is an example of gross pulmonary edema. This patient presented with hemoptysis. He had multiple rounded opacities of different sizes. These are called cannonball secondaries. In this patient, the primary was in the testicle. Spot what the radiological abnormality in this case is. He came with pleuritic pain and sudden shortness of breath. You can see the edge of the lung separated away from the margin of the hemithorax. This is a case of small pneumothorax. The space between the pleura and the periphery are devoid of any lung markings. This patient who was cyanosed and dyspneic had much severe pneumothorax, which has shifted the mediastinum. Clinical diagnosis led us to intervene acutely, which relieved his dyspnea. As we enter the pleural cavity, you can see air gushing out. Later, we inserted an intercostal tube connected to an intercostal drainage system. You can see the air level, air fluid level moving up and down, and when the patient coughs, the air comes out of the tube. This is a water seal drainage system. This is the chest X-ray showing the intercostal tube in the pleural cavity. It's another patient who presented with fever and weight loss. The lung field showed small pinhead size opacities, and the right mid-zone there was a cavity. These are miliary shadows. Let's take a closer look. You might see it a little more clearly. This patient had miliary tuberculosis. This is the classical appearance of right mid-lobe consolidation. One of the cardinal signs of the consolidation is the presence of air bronchogram, which you might see on this chest radiograph. That shows that the shadow is in the lung parenchyma, not in the pleural cavity. This is a pleural effusion. Can you see the homogeneous opacity in the lower part of the right hemithorax with a concave upper margin? This is different to hydropneumothorax, which you saw in a previous chest radiograph, which had a horizontal fluid level. Fluid was aspirated. And it turned out to be blood-stained. Pleural aspiration and analysis of the fluid and pleural biopsy are two important investigations in case of pleural effusion. The fluid was sent to the lab for cytology, estimation of protein, sugar, culture, and other microbiological investigations. CT scan is useful when you want to investigate the mediastinum and also for certain parenchymal lesions, for example, fibrosing alveolitis and also in bronchiectasis. It's also useful for needle aspiration of lung lesions that is done under CT guidance. This is a case of fibrosing alveolitis. Chest radiograph showed bilateral honeycomb appearance. CT showed that these changes were confined to the posterior basal areas and extending into the lung. This man with hemoptysis and confusion had a large right upper zone opacity. On lateral chest X-ray, the consolidation of the apicoposterior area was seen. CT scan of the head was done, showed secondary and surrounded by an area of edema. This patient had bone pain. Therefore, we proceeded with this investigation. Do you know what this is? This is a technetium bone scan. The dark spots are secondary deposits. He had multiple deposits in the bone. This triangular shape, plurally based lesion is a pulmonary infarct. Symptoms are hemoptysis and pleuritic pain. But sometimes if the infarct is large due to massive embolus, patient can present in collapsed situation. This investigation was done to confirm that this is a pulmonary embolism. This is a perfusion lung scan. Multiple filling defects here show that there are multiple infarcts. To confirm that this is due to infarcts, one has to do a ventilation scan and show that these filling defects are well ventilated, but not perfused. This patient had a massive pulmonary embolism, had a pulmonary angiogram, and one can see one pulmonary artery is completely occluded. Bronchoscopy is an invasive investigation. It is used when the malignancy is suspected. In case of infection of the immunocompromised host, where you want to take samples from the bronchial tree. In case of diffuse interstitial lung diseases, when you want to biopsy the lung parenchyma. And also undiagnosed cases of lung opacity, for example, coin lesions on the chest radiograph, and in cases of hemoptysis when the chest radiograph is normal. Following lung transplantation, rejection is detected by doing multiple lung biopsies through bronchoscopy. There are several therapeutic uses of bronchoscopy as well. It is used for removal of foreign bodies, when they are segmental collapsed for removal of mucosal plugs, and also endobronchial laser therapy. Bronchoscopy is done under local anesthesia. Local anesthetic gel is applied to the nostrils and also sprayed into the throat. Bronchoscopy is done without any sedation and without general anesthesia. The scope is passed gently through the nose, and certain sensitive areas within the tracheobronchial tree is sprayed with local anesthetic. This is a vocal cord, very sensitive area, which is sprayed with a lignocaine spray as you go on. The trachea, main bronchi, and main carina, another very sensitive area. You can see the purulent secretions and erythematous mucosa. Case of acute bronchitis, here you can see edema and the orifice is narrowed. There's a bleeding into that. This is a case of malignancy. This polypoidal growth turned out to be a squamous carcinoma. You can see the bronchial orifice is narrowed by about 80%. One can undertake several procedures through the bronchoscopy. Bronchial brushings, and brushings are sent for cytology. This is the biopsy needle. Bronchial washing are also sent for cytology. The biopsy of the bronchial lesions as well as abnormal looking mucosa can be undertaken through the bronchoscope. When the biopsy needle is passed through the parenchyma, one can obtain a transbronchial biopsy of the lung parenchyma. Washing of a segment of the lung parenchyma is called a bronchoalveolar lavage. This is a needle, a bronchoscopic cytology brush, biopsy, forceps, and the bronchial trap used for bronchial washings. A bronchial biopsy. Saline is instilled in through the bronchoscope into the bronchial tree and washings are obtained. Washings are sent for cytology. This is a bronchial brush smear. The samples are then sent to the laboratory with detailed request forms. Cytology is useful to diagnose bronchial malignancy, to determine the cell type, and also in certain chronic inflammatory conditions. Let's look at some of the slides now. You can see cells with malignant nuclei and dense cytoplasm on a dirty background, squamous carcinoma. Cells with dark round nuclei and scanty cytoplasm, small cell carcinoma. Adenocarcinoma, here you can see pleomorphic dark nuclei with fragile cytoplasm. One cell is engulfing another. These are cysts. Trophocytes are bean-shaped in pairs. This causes severe pneumonia in immunocompromised hosts. The stain is a silver stain. These are asbestos bodies. It just shows that the patient has been exposed to asbestos dust, but not asbestosis. This is a histopathology of squamous carcinoma. The epithelium is composed of malignant squamous cells and there's necrosis as well. There are several other ancillary investigations that are useful in the investigation of lung diseases. Simple white cell count will tell you whether there's a pyogenic infection or not. ESR, a non-specific investigation, is useful sometimes to assess the response to therapy. I hope you enjoyed this tape as much as I did in presenting this to you. Let me conclude by giving another exercise and at the end a radiological quiz. Let's take some of the physical signs. Mediastinal shift, the movement of the chest wall, percussion note, breath sounds, vocal resonance, and presence of adult sounds. Let's compare 4 conditions: effusion, consolidation, collapse, and pneumothorax. In effusion, movements are reduced. Mediastinum is shifted to the opposite side if it is a large effusion. Percussion note is stony dull. Breath sounds are absent. Vocal resonance is absent. Usually there are no adult sounds, but in early stages one might hear a rub. So I would like you to compare the combination of these physical signs in consolidation, collapse, and in pneumothorax. This is an exercise for you to do. Let's look at a radiological quiz. It's a patient who came with fever, chills, and rigors with purulent sputum. What is the radiological diagnosis? This is a PA view of chest radiograph.